slide here in a moment. I don't have any conflicts of interest or nothing to disclose with this talk today. I wanted to just take the opportunity to introduce myself. I'm one of the new faces over here at Pediatric Specialists of Virginia in the Hematology Oncology group. I joined the group here back in September. I grew up in Southern New Hampshire, went to undergrad in New Hampshire and medical school at Tufts. I just recently retired from the Air Force after 24 years. I did both my residency and my fellowship on active duty. Residency down in San Antonio at Wilford Hall, and my fellowship up here in DC at the old Walter Reed on Georgia Avenue in Washington, DC. Like I said, I recently just joined the PSV group. It's been a great transition. I'm interested in adolescent and young adult cancer, particularly making sure that our older adolescents and 20-somethings get treated on the right treatment protocols. I'm part of the leukemia and lymphoma team here at PSV and part of the cancer survivorship team as well. Today we're going to talk about sickle cell. I'm just going to do a brief summary of some of the complications we see in sickle cell. I'm not going to go into in depth about these, but more so just so that people are thinking about the ages at which these complications come about. It's important when thinking about those complications to think about what we need to do in terms of their comprehensive health care to make sure that we recognize who may be at risk for some of those complications. Talk more specifically about the role that good comprehensive preventative care has in healthcare maintenance for patients with sickle cell anemia, particularly through childhood and adolescence, and then go through some of the more recent FDA-approved treatments we now have available for patients with sickle cell and discuss some of their indications. Just as a reminder, sickle cell anemia, this is the most common qualitative abnormal hemoglobinopathy that we see. About 8 to 10% of the population in the United States carries the sickle cell trait. And the incidence of birth for patients with sickle cell anemia in the United States is about 1 in 625. It's an incomplete autosomal dominant trait. In the homozygote, so somebody that has hemoglobin SS, there is no hemoglobin A or no normal adult hemoglobin that is produced. And the red cells contain between 90 and 100% of hemoglobin S. There are heterozygote states. The most common is going to be your sickle cell trait, where there is hemoglobin A production, and those red cells contain about 20 to 40% of hemoglobin S. We don't typically see all of the complications that we see in the homozygote states, but as we'll talk about with sickle trait, there are some important complications that can occur in those patients, and important counseling and teaching that needs to be done. So everything that happens in sickle cell is due to a single amino acid substitution. It's in the beta globin gene, where valine is substituted for glutamic acid at position 6, turning a GTG to a GAG. That creates our hemoglobin S. We know that hemoglobin S in the deoxygenated state is much more less soluble than hemoglobin A. It polymerizes and forms rods within the red blood cells. And so rather than red blood cells being able to stretch and squish through small vessels, those rods can get stuck there due to increased velocity and will impair the blood flow, which will lead to the complications that we'll see in sickle cell disease. One of the things we do know is that if we can increase the hemoglobin F a patient is making, that will decrease that patient's polymerization due to deoxygenation in the hemoglobin S state. Certainly, as we're going through, if folks do have any questions, please feel free to jump in and ask. Just please remember to unmute yourself so I can hear you and answer your questions. So, as we all know, there are a lot of different complications that we see with sickle cell disease. The earliest of which we'll see is dactylitis, or painful swelling in the fingers and toes, which we'll often see in infants and toddlers. There's an increased risk of bacterial infection, particularly in the first 5 years of life. Other vaso-occlusive events or pain crises due to bony infarcts primarily that we'll see as children grow. Children can have cerebrovascular accidents, can have sickling in their chest leading to acute chest syndrome, splenic sequestration where that polymerization and hemoglobin S cells getting stuck and built up in the spleen. Can lead to retinopathy, pulmonary hypertension, other CNS changes that can lead to learning and behavioral concerns, and even end-stage renal disease. So really looking through that list, almost anywhere in the body where you have small capillary beds and areas that at the end of organs where the vasculature becomes very small, that is areas of risk for patients with sickle cell where they can have polymerization and can have buildup of hemoglobin S cells that can lead to downstream problems like infarcts and strokes. When thinking about all these different complications, it is important to think about the ages that they occur in, because that is going to help when we go through our comprehensive healthcare, thinking about what are going to be some of the important educational topics to discuss with families with kids with sickle cell disease, and what things we might need to be screening for. So things like dactylitis and splenic sequestration and higher infection rates, we're going to see those in infants and young toddlers through preschoolers. We start to see long bony pains and trunk pains as kids get older, as their primary vaso-occlusive events leading to pain crises. And then other complications like retinopathy, we'll see as kids get older, particularly into the teenage years, where we can start to see retinopathy, gallstones, avascular necrosis, primarily of the femoral heads, as children get older. Throughout, we can see problems with delayed growth and development, so that's an important thing to think about. And strokes, which are probably one of the most severe complications we can see with children with sickle cell, we'll start seeing in our late toddlers, around age 2 to 3, through early elementary school. But that risk actually continues through adulthood for patients with sickle cell disease. So we're going to kind of talk about this patient. We're going to call her Katie. I picked Katie since both my stepdaughter and my stepson's wife is named Katie, so I've got a lot of Katies in my family. But this is little Katie. She's now presenting to you for her 2-week well check. She is the firstborn child of parents who both immigrated from Africa. She was born here at Inova Fairfax Hospital. And on review of her Virginia newborn screen, it shows that she has an abnormal hemoglobin electrophoresis with F and S. So the first thing we want to talk about is, what do we need to do with that, or what do we need to think about with this for Katie? So the first thing that's important is to know what testing your state is doing for their newborn screens. And so we're lucky here in the state of Virginia that our Virginia Hemoglobinopathy Screening Program is done in the Division of Consolidated Laboratory Services. They actually do 2 types of tests to confirm whether there is an abnormal hemoglobin or not. This is not true in all states around the United States. When hemoglobinopathy testing first started, primarily states were doing a single method to identify abnormal hemoglobins. And so when this started happening 20, 30 years ago, we often would immediately repeat the hemoglobin electrophoresis for confirmation. In states that are doing the 2-part testing, it is very, very accurate, almost to 100%. So we don't necessarily need to jump to doing a hemoglobin electrophoresis right away for these patients because the testing results that we're getting accurate. Here in Virginia, we do an isoelectric focusing as the first test, which is going to be your standard Western blot that people probably can remember back to medical school and biochemistry class that we did. And then they will do high performance liquid chromatography, which is a high pressure liquid testing mechanism that will elucidate the differences between hemoglobins. And doing both of those techniques, it's pretty accurate, the test results that we're going to get here in the state of Virginia for our newborn screens. So we're pretty confident that Katie does have FS as in her newborn screen. So remember that in the reporting in your newborn screens, the hemoglobins that are the most quantitative or most plentiful are going to be reported first and then in descending order. So F is typically going to be the first hemoglobin or fetal hemoglobin, obviously in newborns, that you're going to see on all of your newborn screens. So Katie has FS. So looking at what her potentials are is she may have hemoglobin SS, standard sickle cell anemia. She could have sickle beta 0 thalassemia or sickle with hereditary persistence of fetal hemoglobin. But she has a sickle variant. There are other variants that we think about, FSC for hemoglobin SC disease. FSA may be a patient with sickle beta plus thalassemia, or FSV, or FS in a different letter, which is sickle with another hemoglobin trait that would lead to a variant of sickle cell. For all of these patients, when you have S is in the second place, these are patients with variants of sickle cell. The goal should be to refer them to a sickle cell center and initiate penicillin prophylaxis in these patients by age 2 months. There are other hemoglobin. Of course, my phone is ringing. We're just going to let that go to voicemail. There are other hemoglobinopathies that you will see that will require hematology referral, but not necessarily penicillin prophylaxis. FC or hemoglobin C disease, F with E or O are going to be different variants of beta thalassemias. If you just see an F, that could be a patient with beta thalassemia major, or could be a premature infant that hasn't started making any A yet, or an FA and a V, a variant hemoglobin that we're going to want to do some additional testing for to identify. And then probably the most common thing that you're going to see are going to be your traits, FAS and FAC for your sickle cell trait and your C trait. So it's going to be important that you have educational materials for patients that you're seeing in your practices, to be able to give them and be able to talk and start doing some counseling and some anticipatory guidance for patients with sickle cell trait in particular. In this case, Katie's parents immigrated from Africa, so they may not know what their sickle cell status is. It's not uncommon, often in the obstetrician's office, that sickle DEXs will be done that may identify a sickle cell trait. But sickle DEXs will not identify other variant hemoglobins like hemoglobin C or beta thalassemia, abnormal hemoglobin B. So certainly offering to families or recommending that they follow up with their providers and getting CBCs and full hemoglobin electrophoresis so they know what their status is, so that proper family counseling can be made for future children. And then you want to provide that educational material, making sure families understand what the genetics behind sickle cell disease are and what trait means. Typically, this is often done in the newborn period when this is first identified. But what I would also recommend is that there should be repeat counseling for your adolescent patients that do have sickle cell trait. The reason is what is discussed in the newborn period is probably not going to be remembered by families when their patients or their kids get to adolescence. And I think it's important for the adolescents to hear this themselves. For them to understand what the genetics are, as they are obviously sickle cell trait, meaning that if they were to get together with another patient with trait, then they have a 1 in 4 chance of having a child with sickle cell disease. That may be important for families to understand for family planning. But more importantly, for them to understand that with sickle cell trait, they do themselves have some potential risk factors that they need to be taking a look out for. Probably the most important of which is exertional rhabdomyolysis and exercise-related sudden death. It's important, and this was actually first identified back in military recruits back in the 70s, that unconditioned patients with hemoglobin S disease that immediately jumped in to full boot camp had a high rate of exertional rhabdomyolysis and some exercise-related death. Using traditional heat stroke precautions, making sure that patients are getting hydrated, and making sure that patients are building up in terms of their exercise tolerance is important to prevent that. And it's important for these kids to know that. And if they have underlying reactive airway disease or asthma, for that to be well controlled as well, so that doesn't lead to challenges with this. This is something that we, when I was back at Walter Reed, we'd often offer for adolescents to come back to our clinic. We have that available here at the Pediatric Specialists of Virginia as well in our sickle cell clinic, that we're happy to see these patients to do that counseling and to make sure that they understand the importance of recognizing this. And then as patients get older with sickle trait, there is increased risk and rate of end-stage renal disease, different renal cancers, and venous thromboembolic diseases. So there's a huge role for the primary care provider for Katie. Although she will be coming to see us frequently in our sickle cell program and our sickle cell center, there needs to be good collaborative care between the primary care provider and the sickle cell specialist. If you yourself are taking care of patients with, who have sickle cell disease, then the National Institute Heart, Lung, and the NIH, the National Heart, Lung, and Blood Institute, has a great online PDF you can download and have on your computer that will help walk you through what some of the important preventative care is and how to manage some of the acute problems that you're going to see in your patients with sickle cell disease. I'll reference back to this as well. In 2014, an expert panel got together at the National Institutes of Health and really looked at the studies and practice that were out there for taking care of patients with sickle cell disease and really came up with a good evidence-based management guide that's also available at the NHLBI as well for download, to have an understanding of what studies have been done and this panel reviewed that and coming up with what the best recommendations were for both preventative and acute care for patients with sickle cell disease. But instituting good preventative care for patients with sickle cell disease has really made massive improvements or major improvements in the both life expectancy and the complications that we see in patients with sickle cell disease. In the past 40 years, the life expectancy has increased from, from many of our patients not getting out of childhood to the vast majority of our patients living well into their 50s and 60s. This has certainly given us another challenge as pediatric hematologists, and we'll talk about that a little later, is that finding medical homes for pediatric patients who are aging out of pediatric care and needing good adult primary care and adult sickle cell treatment centers. So to kind of go back, we talked about the importance of that referral to sickle cell center by age 2 months. And the other thing is to start prophylactic penicillin. So this was one of the major landmark studies that was done out of Dallas. In the Dallas cohort, where they started prophylactic penicillin by age 2 months. The dose is very easy. If you're under age 3, it's 125 milligrams twice a day, and over age 3, 250 milligrams a day. By instituting that, in this study, they were able to decrease the rate of pneumococcal septicemia by 84%, and there was a 100% reduction in death. So major improvement in the quality of life and decrease in the morbidity and mortality associated with infections in those first few years of life. If patients are penicillin allergic, then erythromycin is an acceptable alternative. If patients have parents or family members that are penicillin allergic, then the patient should have penicillin unless they prove themselves to be penicillin allergic. Penicillin should be continued through at least age 5 unless that patient has undergone splenectomy or has a history of invasive pneumococcal diseases. And they should have completed their vaccination series that we'll talk a little bit about, their pneumococcal vaccination series, and ideally their meningococcal vaccination series as well. And then what's going to be really important should be collaborative between the primary care provider and the sickle cell center is doing good preventative education for these families, particularly if this is a family that doesn't have family members that have sickle cell disease, or if this is their first child and going to be this first family's experience with this disease. So doing simple things, teaching families how to do spleen exams, extremely important. I've had many families that they were the first to identify that when their children were sick that they were experiencing splenic sequestration. And that was able to allow discussion and disposition to the emergency room or a center that can take care of that problem and getting them quicker to the care that they need. Really talking about, importantly, how do we prevent vaso-occlusive crises, pain crises? Importance of pain crises will come out during illness. So being very cognizant when kids have fever or have illness that may bring out pain crises. Making sure that children are maintaining adequate hydration, particularly if they are outside in hot weather or they're having illness, as dehydration is an important factor that leads to vaso-occlusive crises. And avoidance of extremes in terms of hot or cold, especially the cold. So making sure that kids are dressed properly when they're going outside, making sure that they have the proper clothes, particularly in this climate where we do have winter, and that they can recognize other areas that people may not think about as potential triggers. When I was stationed in Mississippi, one of the largest or biggest spikes that I would see in kids coming in with pain crises was in late May and early June. And it seemed odd to me after having trained and spent most of my time up in the Northeast when the winter time was the problem time for most families because of the weather. And in the end of May, beginning of June, it was in the upper 80s and getting into the 90s every day. The issue is that the Gulf and most people's pools were not that warm. And so people were going swimming to cool off, but the pools themselves were only in the upper 70s and lower 80s. Kids were in for too long, getting cold and setting themselves off into crises. So really recognizing those particular factors and giving people the proper education. And once I realized that, then I instituted the 20 minutes in, 10 minutes out rule for pools and the Gulf in terms of when I was educating families, certainly wanting kids to be active and be able to enjoy those things, but making sure that they weren't putting themselves at risk for developing problems. Coming up with pain management plans for families and making sure that families understand the different medications that may be used, such as ibuprofen, Tylenol, or potentially even narcotics, and so that they're properly used and families can identify what medications may be appropriate based on levels of pain. And when, more importantly, when patients should be coming in for medical evaluation during pain. Fever management, really honing in the importance that even with penicillin and our vaccinations that we have, we still see invasive pneumococcal and meningococcal and invasive diseases, bacterial diseases in young children. And so that fever is an emergency, and that for children with temperatures over 101 or sustained over 100.4, they really need to be coming in for prompt medical evaluation and seen. And making sure that families understand what they need to know about their patients for their, what I call their emergency care list. Knowing their medications and their doses, knowing what baseline labs they have, because that's going to be an important factor for discerning if particularly a febrile illness is having a significant effect on a patient or not. Has their hemoglobin changed from baseline? Has their reticulocyte count changed from baseline? And physical exam findings. There may be children that had history of splenic sequestration in the past that do have mildly enlarged spleens at baseline. And so knowing that that is a normal finding and not a new finding is going to be important for that acute care provider that may be seeing them in an emergency situation. Immunizations, these are very important. They're important for all kids, but particularly because of the additional invasive diseases because of effects on the spleen, particularly that sickle cell has. Making sure that children are getting their full series of Prevnar 13 at the appropriate ages, doing catch-up for children that have not. If children, although most children now have had the 13 series, but if you are seeing an older adolescent that maybe got the Prevnar 7 series, then they should be offered booster for Prevnar 13 to get those additional 6 serotypes in. Adding at age 2 years, a dose of the polysaccharide vaccine. We start that at age 2, and then they should get a booster sometimes between age 3 and age 5 years. If they haven't had any pneumococcal vaccines, you want to start with the Prevnar 13, and then several weeks later add in the polysaccharide vaccine. Now that we have our meningococcal vaccines that are that can be given down to low ages, Menveo down to age 2 months and Menactra even down to age 24 months, we would certainly want to advocate and work for making sure that those vaccinations are given at early ages for our patients to give them extra protection. And then certainly, as important for all children, making sure that patients with sickle cell disease are getting their annual influenza vaccine. Many children with sickle cell disease will have mild restrictive lung disease or reactive lung disease because of their sickle cell disease. So getting influenza on top of that can set them up for having more significant complications like secondary bacterial pneumonias or acute chest syndrome. I certainly get asked the question, or been asked the question, now that we have all these vaccines, and certainly when the initial penicillin trials were done back in the 80s, these vaccines were not available for children. So is it still necessary to give kids penicillin? I think that's a great question. because it is because of the positive effect and the major decrease we've seen in penicillin and the very minimal secondary or side effects we see with that, nobody's ever going to do a study that's going to look and say, should, give half the kids not penicillin and half the kids penicillin. So I don't know that's a question we're ever going to answer per se, but I think advocating to make sure that kids are getting properly immunized in addition to their penicillin is something great the primary care provider can do to help keep them safe from infectious etiologies. We certainly do and follow routine laboratories in kids and have other testing that will help us identify maybe kids that are at risk or having complications from their sickle cell disease. Certainly through the first couple years of life, we much more frequently will get blood counts, follow their percent hemoglobin F to see where they're going to settle out. And then often those tests are spaced out to annually. Depending on where these families live, some of these visits and some of these laboratories may be done at the primary care provider versus coming to the sickle cell center to have that testing done. We then, after age 1, will start taking a look and following routine hepatic, renal, and urinalyses in kids. And then we're going to talk a little bit more about RBC phenotyping and why that's important for you to do. Getting O2 sats, so knowing what they're, just like understanding what a child with sickle cell's baseline exam and baseline labs are, knowing what their baseline oxygen saturation is. So if somebody's baseline oxygen saturation is 96 and they come in with cough and they're 96, that may be not as concerning as somebody who has a baseline that's 99 or 100 and coming in with a 93 or 94% oxygenation. That may be a child that is starting to develop pneumonia or an acute chest crisis. At age 2, we start doing routine transcranial Doppler ultrasonography. This is to identify children that may be at risk for having stroke, looking for increased velocities. Fortunately, and we'll talk a little bit about medications that we use, we're seeing this less and less with the early introduction of hydroxyurea to our patients. Getting annual or getting as needed pulmonary function testing for kids that have had acute chest or have had changes in their oxygen saturation over time. For kids that may be coming in and seeing you and having changes, particularly in changes in school performance, those may be kids that are having subtle or not asymptomatic strokes. So considering CNS imaging for them with MRI. And then starting at age 10, particularly for those patients with hemoglobin SC sickle cell disease, adding in having them get annual dilated eye exams to early identify any retinopathy that may be developing in these kids. So talking more specifically in terms of red cell phenotyping, depending on where you are and what your practice is, children may be going to their local sickle cell center for most of their acute care complications. And so that if they are sick and are needing blood transfusions, that they're going to those centers. But if you're distant from those centers or taking care of these kids in a community setting, then you may be with, if they're coming in ill or coming in with an aplastic crisis, providing their transfusion therapy or transfusion support through those illnesses. It's important that if you're going to transfuse a patient with sickle cell, that you do extended phenotype typing, and we'll talk a little bit about why that is. So when we think about, blood typing, we think obviously about ABO and about RH, which is actually RHD, which is the most immunogenic of the blood antigens. But there is different variances of immunogenicity of the different red blood cell antigens that we find on our red blood cells. So even things like K, which is a KEL type, other RH types like C and E have between 1% and 5%, meaning that if you have a mismatch for those, you have an up to 1% to 5% chance of developing an alloantibody against that antigen. And if you match that up with the difference that we see in those antigens, particularly between a Caucasian population and an African-American population, recognizing that in this country, the majority of the blood supply is from a Caucasian population, you can see some major differences in things like the Rh antigen C being over 2/3 in Caucasians, but only 1/3 in African-Americans. The little c, little e subtype being very common in African Americans and very uncommon in Caucasians. And certainly differences in some of the other blood types as blood antigens as well. So what our recommendation is if you are going to be transfusing these kids and taking care of that part of their care, you want to do red cell phenotyping so that you know what their extended phenotype is for at minimum RHC, E, your KEL, and then many would argue as well as your KID and Duffy. And if you need to transfuse, then you not only want to match for obviously your A, B, O, and your RH, whether they're positive or negative, but you're going to want to match them. So if you have a sickle cell patient that is little c, little e, big K, that you're matching the blood to those phenotypes as well. And then if possible, KID and Duffy as well. If you match all of those, the likelihood of a patient developing alloantibodies is very, very low. Without doing that, it adds up to about 5 to 10% of patients will develop alloantibodies. When I was stationed down in Mississippi after Hurricane Katrina, this unfortunately wasn't a practice that was done in the community that I started seeing sickle cell patients in. And almost 10% of the sickle cell patients that I saw had alloantibodies, which made it more challenging when we were needing to transfuse them. So I alluded a little bit to hydroxyurea. This is something that you're going to commonly see. Almost all of the patients with sickle cell in your practices are on. We typically, for patients with hemoglobin SS and hemoglobin S beta 0 thalassemia, are going to start this at age 9 months. So about a decade ago, the Baby Hug trial was published. This looked at primarily the safety of hydroxyurea and starting it at a young age, but also had secondary look at maintenance of end organ function. And what this trial showed is that it was very safe to start. And so all patients with hemoglobin SS and hemoglobin beta 0 thalassemia, there's high evidence to start those patients. But we have a fairly low threshold for our patients with hemoglobin SC or hemoglobin S beta plus thalassemia. For those patients that are having recurrent vaso-occlusive crises, recurrent hospitalizations, particularly if there is a change or it's interfering with quality of life. Certainly any of those patients that do experience an acute chest syndrome or a splenic sequestration, those patients will also benefit from hydroxyurea. You know, when hydroxyurea first came out, sort of the teaching is that hydroxyurea increases your hemoglobin F, and that is the mainstay for the improvements that we see. And that is certainly one of the major positive effects that hydroxyurea has in patients with sickle cell disease. And certainly we monitor their hemoglobin F, and by monitoring white blood cell counts and platelets and liver enzymes, maximize their tolerated therapy or their tolerated dose to maximize the percent F that we can get that patient to produce. But for many patients with sickle cell disease, prior to initiation of hydroxyurea therapy, they have very high levels of white blood cell counts and very high platelets because their bone marrow is just turned up, which makes them have an overall pro-inflammatory state, so that when they start sickling, they've got lots of white cells around to set out cytokines and lots of sticky platelets to help with that and promote that vaso-occlusive event. So hydroxyurea also for these patients will get them back down to having more normal counts, both white blood cell count and platelets. It also releases nitric oxide from the vasculature, which does cause some slight vasodilatation. So there's multiple positive effects that hydroxyurea has that will improve quality of life and decrease the risk of complications for patients. So the one question, this will certainly always come up. There have been, people have looked and there have been studies. There have been no changes in terms of altered fertility. Certainly if patients with sickle cell become pregnant, we do not have them on hydroxyurea during their pregnancy because of the potential teratogenic effects on the newborn. And there has not been a proven increase in carcinogenicity. So what I tell families is that patients that are going on hydroxyurea, their children have the same risk of developing leukemia as any other child does. Okay, Katie's now growing up. She's getting ready for school, and parents are interested to know what other maybe specific school guidance we need to think about for her, and if there's any other specific considerations we need to have for Katie. So some of the important things. It's really important for kids to sickle cell to participate and be active. Activity is important in all children's health, and that includes kids with sickle cell. So we want them to participate in PE in school. We want them to participate in sports. We want them to be running around and playing with kids. But it's important to recognize and counsel that this really needs to be done at their own pace. If a child with sickle cell has a baseline hemoglobin of 8, there's no amount of training that's going to be able to get that child's stamina up to that with a comparable child that has a normal hemoglobin of 13 or 14. Do we want them out playing soccer with the kids? We do. But if they get tired, then they need to be, the coaches need to know and schools need to know, they need to be able to come out of play, rest. This is a great time for hydration when that happens, because it'll be really important if they are going to be active, particularly outside in warm weather, that they're maintaining good hydration to prevent the risk of vaso-occlusive crises. Hydration is important not only during activity, but even during the school day. Obviously, we're virtual schooling now for almost everybody, but hopefully once vaccine becomes available, maybe the end of this school year or definitely by next school year, kids are going to be back in the classroom, everybody full time. I recommend that kids with sickle cell, if they don't have easy access to the water bubbler, that they have a water bottle at their desk so that they can continue to drink. And teachers need to understand that if there are dedicated bathroom times, that kids with sickle cell may need to use the restroom at different times. Kids with sickle cell very early on develop isostenuria and cannot concentrate their urines like normal kids do. So they're going to need to use the restroom more frequently than other children. And if you're wanting them to be super hydrated to prevent any secondary complications, then they're also going to need to go to the bathroom more frequently. So it's important for schools to understand this. You want to reiterate that we still need to be cognizant of avoiding temperature extremes. Avoid swimming in cold water, or if the water is cooler or just warm like earlier in the season, swimming for short periods and then coming out and fully warming up. And if kids are going to do any outdoor activities or winter activities, then they need to be dressed warmly and coming in periodically again to warm up to prevent vaso-occlusive complications. We need to really think about academics for these kids. Depending on if children are having a lot of complications, they may be in or out of school. They may have different learning complications if they've had stroke or have had silent strokes. So making sure we identify the kids that would benefit from being on an IEP or a 504 plan. Having a pain plan for school so that if a child with sickle cell starts to develop some mild pain, they can go to the nurse's office and get some Tylenol or ibuprofen to turn things around, or if they're having some mild pain, they can have those things so that they're not missing school just if they're having a mild pain in their foot. And then making sure that schools understand the importance of recognition so that if a child's not feeling well or has a fever, that parents are contacted immediately so that they can seek prompt medical care. Following up and making sure that kids aren't having too many absences, and if they are, figuring out what we can do to prevent that. For kids to learn, they have to be present, and so school absences don't help anybody in terms of their performance and achievement in school. Following their academic achievement, and if we're seeing that there are some changes or particularly some downward trajectories, thinking, has this a child that may be having some silent strokes or maybe having some changes, CNS changes, because of their sickle cell that we need to identify and work with. And then finding, certainly with all kids, finding good mentor relationships, camp opportunities, particularly if maybe kids with sickle cell are not in communities where they're around lots of other kids with sickle cell, for them to understand that this is a disease that we can live with and that we can do well with. I've got lots of patients with sickle cell who've gone on to medical school and nursing school and have gone on to have great careers, and that should really be the trajectory for all kids with sickle cell disease. Travel, really the same things. Hydration, dressing warmly, certainly moving around frequently, particularly if you're on an airplane. And this would go for patients with sickle cell trait as well, who are also at increase for venothrombotic events or thromboembolic disease. Travel in non-pressurized aircraft is a problem. So typical air travel is in a pressurized aircraft and not an issue. If you have somebody with sickle cell that says that they want to go skydiving, probably not a good activity between the temperatures and the non-pressurizations at that height. That's going to be a setup for vaso-occlusive events and complications. But standard travel in airplanes, cars, buses, trains, there's not any increase. Just making sure that we're dressing appropriately for the temperature and staying well hydrated and getting out periodically to prevent any thrombotic complications. Okay, Katie's now coming back. She is now a young adolescent. And so now we're starting to introduce our heads exams and thinking about Katie. So what are gonna be what's the most important part of that? It's kind of a trick question. It's all important for kids with sickle cell. Important to know their home environment. Are they getting the medications that they're prescribed? Are they able to access and come in for both comprehensive and acute care when they need that? How is their school going? Are they experimenting with drugs or alcohol or smoking? And certainly children with sickle cell, because of chronic sickling, many of them will develop restrictive or reactive air disease, even if they haven't had acute chest syndromes. So adding things, and deterring smoking or other things that would worsen their lungs is going to be important. Understanding and making sure that adolescents understand that they can have children, that they are fertile, and if they are sexually active, then that they're taking the proper precautions not to have unwanted pregnancies. And if they get old enough and they're at a point where they would like to have children, that is a planned event, and that they're under the care of a hematologist and a high-risk OB specialist to get them through that potential pregnancy. And then this is the time to start working on a transition plan. Making sure that, certainly you've been working with the parents up to this time, making sure that they know what their baseline labs and baseline medicines and other things are. But this is an important time to bring the adolescent into that and make sure that the adolescent knows what their baseline is, knows what their sickle cell history is, understands their medicines and doses, understands themselves what could put them at risk for having sickle cell crises or complications. And then as they're getting older, knowing, is this a family that's going to be moving, off to college and is going to potentially transition out of your practice and out of their local sickle cell center sooner, or somebody that's staying local, and having a plan for who is going to take over their primary care and transition that plan. And is there an adult sickle cell center that may be available that the sickle cell care could be transitioned to as well? So talked a little bit about, certainly there are risks, particularly increased risk of venous thrombotic events during pregnancy. So, having those conversations, making sure that appropriate contraception is used, that that these adolescents understand what their risk of transmitting the disease is, as it is a genetic disease, and other complications. So this is a great time during these visits to reiterate those, that education to families and those adolescents. Okay, I'm going to change pace a little bit, talk about some of the new or novel treatments that are coming out or have recently come out and are FDA approved now for patients with sickle cell. This may be the first time that you're hearing about some of these. So we're going to talk a little bit about stem cell transplantation, and then I'm going to talk about 3 different medications that were all FDA approved last year for sickle cell disease, and then talk a little bit about what's exciting that I think in the hematology world is the gene therapy options and opportunities for families. So certainly, when I started training, the only cure that we had for sickle cell disease was bone marrow transplantation. This has been used for several decades, but excuse me. But traditionally, we've really only reserved bone marrow transplantation for those patients that have very severe disease, secondary to the morbidity and mortality associated with transplant. The transplanters don't like to hear this, but I think of transplant in one way is, changing one disease process over for another. So certainly if you have leukemia that is going to be 100% terminal unless you get a transplant, that's a little bit easier to trade off the potential for morbidity and mortality with the transplant. But if you're having sickle cell, then things may be a little bit more equivalent there. Certainly, we look at all the different types of transplants that are available. With matched siblings and then even with some cord transplant, there's much less risk of having chronic or acute graft versus host disease, which decreases some morbidity and mortality for patients. The ability, can we find potential matched donors for patients? And unfortunately, since just as within our blood supply, much of the bone marrow donor supply or people that have volunteered to be donors are Caucasian, so there's not as many African Americans in the donor lists. So it may be difficult to find a patient or find a match for patients with sickle cell disease. And then there's some newer protocols that are looking at haplotransplant, so a half transplant from one of the parents. Certainly many centers have gotten much better through clinical trials and looking at different conditioning regimens that aren't as high intensity, so decrease those risks of infectious complications around the transplant, but that still lead to successful engraftment for the transplant. So we've gotten much better over time, but there are still some significant potential risks associated with transplant for our patients with sickle cell. Endari, this was the first medicine after hydroxyurea that was FDA approved for use with patients with sickle cell disease. Its indication is to decrease acute sickle cell disease complications in children greater than age 5 and adults is the FDA approval. It does this by reducing the oxidant damage to red blood cells by improving the redox potential of nicotinamide adenine dinucleotide, or NAD, which is a coenzyme in the regulation of oxygenation in red blood cells. The trial, or the clinical trial that helped lead to the FDA approval of this was an NIH trial, the phase 3 trial looking at the safety and efficacy for L-glutamine. And what this found is that the average cumulative crises count was reduced by about 25% in the Endari group versus the placebo group. It's an oral powder. It's given twice daily. The dose ranges between 5 and 15 grams. Common adverse events for patients are constipation, nausea, cough, and abdominal pain. And the cost is about $40,000 annually. For patients that are having significant recurrent crises, despite being on appropriate dose or max dose hydroxyurea, this may be something to consider for those patients. The next drug, which is crizanlizumab, was FDA approved in early November of last year. Its indication is to reduce the number of vaso-occlusive crises in patients aged older than 16. So it is not approved in children under the age of 16. It binds to P-selectin, which is a cell adhesion molecule, which blocks the interaction of P-selectin glycoprotein on neutrophils and monocytes with the activated endothelial cells and platelets. The study that led to the FDA approval came out in 2017. And what this showed was a 45% reduction in the annual number of vaso-occlusive crises in the treatment group. This is a once monthly intravenous medication. Common side effects we see are nausea, arthralgia, and pyrexia. However, as with many of the new monoclonal and targeted therapies, it is still quite expensive and more than $100,000 annually if given. So although there is improvement, this is one that's certainly a challenge in terms of affordability and approval from insurance. The newest medication that came out was just a few weeks after the crizanlizumab is Velexator. And this indication is to reduce hemolysis and increase hemoglobin in patients that are older than the age of 12. It binds to hemoglobin S and increases the affinity for that hemoglobin to oxygen, which leads to inhibition of hemoglobin S polymerization. There's a phase 3 trial, the HOPE trial, that showed that patients that received Oxbryta, about half of them increased their hemoglobin greater than 1%. And a secondary finding was that there was a decrease in sickle cell or occlusive events in those patients. There's now an ongoing study, the Hope Kids 2 trial, that's looking at TCD velocities. And for those children that have elevated TCD velocities that put them at risk for having a stroke, can putting them on Veloxator decrease or change that trajectory for children and put them back at a lower risk for having a CNS stroke. There are oral tablets that are given. The common adverse events: nausea, diarrhea, headache, abdominal pains, and fatigues. And again, unfortunately, this medicine is still quite expensive, which may make it potentially not available based on insurance coverage and availability. It's about $100,000 a year. More exciting that I think that is coming out are going to be the gene therapy approaches for sickle cell disease. There are two different approaches. They involve with genetically altering a patient's own hematopoietic stem cells, either by replacing that single amino acid in the beta globin gene, so that instead of making hemoglobin S, using CRISPR technology to fix that to make so that the patient is making normal beta genes so that they can make normal adult hemoglobin, or to swap out the activation so that instead of activating the sickle cell beta globin gene, that they're reactivating the gamma gene that we see in our fetal hemoglobin. So that kind of turning these patients back into infants, and that they're making predominantly hemoglobin F instead of making hemoglobin S. There are clinical trials all over the country that are looking at these different methods. Certainly, stem cells are collected from patients. Often this is done through peripheral stem cell harvest. Once the number of stem cells is up, they're genetically modified in the lab. Patients do have to undergo some chemotherapy so that they can kind of purge some of their bone marrow and open up space for these new cells to come in and engraft. But since these are the patient's own cells, there's not that risk of graft versus host disease and those type complications that you'll see with allogeneic stem cell transplants. And for many of these patients, you don't need to get 100% engraftment. If you can get them to be 40, 50, 60% engraft, you could turn somebody who was sickle cell into somebody now that has more of a sickle trait phenotype. So I think these are very exciting. They're mostly still only available in clinical trials at centers around the country. But I think as the technology and the understanding of the CRISPR technology and how we best do this for patients, this is going to be something that's much more widely available and potentially curative for our patients with sickle cell disease.
Dr. Newton, oh, perfect. I was just going to make sure, Dr. Newton, that you can see the questions in the chat, which I can read to you, but I'm just going to butcher a couple of the pronunciations.
Okay, I don't have the chat up, but I can, oops, let me see if I can.
Okay, if you don't mind.
Yep, I pulled the chat. I just pulled the chat up.
Okay, awesome.
Okay. So I can start with a couple of these questions, and certainly if folks have other questions, please feel free to let me know. So the first question is, should sickle cell trait adolescents not be put on oral contraceptives for amenorrhea or dysmenorrhea? So, you know, I think that certainly, just as with all patients, we do know that patients with sickle trait do have a higher risk of venothrombotic events than patients without trait. That certainly, if, you know, as with anybody that has increased risk, if there's an option for using progesterone only treatments like Depo-Provera or progesterone only oral contraceptives, then that would be preferable. But anytime that you're taking a look at, you know, using hormone therapy, from particularly amenorrhagia or dysmenorrhagia, you kind of needed to weigh the risks or benefits. If I had a patient with sickle trait that was just absolutely miserable and did not have any improvement on progesterone only therapy, I would certainly talk to them about the potential for some increased risk. that increased risk doesn't mean if they go on estrogen-containing oral contraceptives, they're going to have a 10-fold, 20-fold, 30-fold. It will just increase a few-fold, but important for patients to understand the risks and the potential benefits, and particularly if that patient does go on estrogen-containing contraceptives, that they are taking the other precautions. They're not smoking. They're always staying very well hydrated. They're getting up and walking around if they're taking airline flights or they're taking long car rides, so that you're doing everything possible to minimize that risk. And then next question I have in the chat is, should sickle cell trait adolescents who get recruited for sports in college see a hematologist one time? I think that's a great question. I am biased, so I think that it probably does behoove, if the primary care provider doesn't necessarily have the time to really go through in terms of what that risk is for heat stroke and acute rhabdomyolysis, or it's going to help by having that adolescent hear it from a specialist. I think that that's a very reasonable referral, and we're certainly happy to do that here in our sickle cell program for you. More important, I think that it's probably more important to have that discussion with the adolescent before they start in competitive sports, even at the junior high and probably more so the high school level. The recognition of this risk is pretty well, and if you go to the NCAA website, there's actually very good resources for counseling and resources for patient. So I'm much more inclined to think that the colleges the coaches at the college level are going to be adhering to those guidelines in terms of prevention for heat stroke and rhabdomyolysis events. But like I tell families, I don't know, and I kind of say I was stationed in Texas for a while, I was used to dealing with military families who were moving around. You know, I can't say that the high school coach in Odessa, Texas is going to understand what those risks are and are taking the same precautions. So really making sure that those families and those adolescents understand the risk and can make sure they advocate for themselves so that they can prevent any complications and so that they can be active and participate in sports if they want to, I think is important. And happy to take if anybody has any other questions, people can type them either into the chat now that I have that up, or please feel free to take yourself off mute, and I'm happy to take those questions as well.
Okay, if there are no more questions, thank you so much, Dr. Newton. Appreciate it. And I will put this all on the ANOVA CME site as well as upload the recording.
Okay, excellent. Well, thanks everybody, and everybody have a great weekend.
Thanks, you do the same. Appreciate it.